Good evening, everyone. On behalf of Vero Healthcare Magic Ma'am, I'm welcoming Dr. Veronica Arora, the convener of this program, specifically on Autism Awareness Month. And as you know, Dr. Veronica Arora is a well-known in genetic segment in India, and she has done her MD, MS in obstetrician and DNB in clinical genetics with a gold medal from Gangaram. And she is a special interest in autism ADHD part also, ma'am. And Dr. Veronica Arora has published over 70 papers and books, chapter national and international journals. She has been more than 500 online and offline lecture for awareness enhancement of genetics in India. And she's been secretary of Delhi chapter in ANBAI. She's a managing committee member of National Spa Society. She is a treasurer in Delhi SFM and executive member of Society of Indian Academy of Medical Genetics. She is now secretary of iSOPARB Delhi chapter, which is a great achievement. And she is also advisory board member of Myositis Society of India. She has been member of Umid Initiative, Department of Biotechnology, the Government of India, and member of Genetics and Fetal Medicine Committee, AOGD. She is member of Genetics and Fetal Medicine Committee, OXD. So I'll request Dr. Veronica to invite our convener, Dr. Anita Joya ma'am, and to further go for the program, ma'am.
Thank you so much, Viro Healthcare and Scan Diagnostic, for having this program today. So, good evening, everyone. It gives me great pleasure to welcome you all to this important webinar on autism spectrum disorder. This is a condition that continues to challenge our understanding, yet it also inspires us with stories of resilience, growth, and individuality. Autism is not a one size fits all diagnosis. It is a spectrum, and every individual with autism has a unique set of strengths and needs. As clinicians, as educators, researchers, and caregivers, our role is to better understand this diversity and translate our knowledge into a meaningful support, be it the support in treatment or the support in early diagnostic or prevention of this disorder. Today's session brings together all the experts who will help us navigate the evolving landscape of autism, from clinical features, diagnostic methods, to treatment, and also to intervention and prevention. We hope this webinar will not only expand our knowledge, but also spark conversations and reflections that lead to more inclusive and compassionate care for individuals with autism and their families. So we have the Delhi chapter of iSOPARB and the Delhi chapter of Neurodevelopmental of the IAP coming together to host this webinar. Delhi chapter of iSOPARB, I would like to invite the president, who everyone knows, Anita ma'am, to take the proceedings forward. And from the NDP chapter, we also have Praveen Suman ma'am here. Anita ma'am.
Thank you, Veronica. Thank you for introducing the subject so well. We all know that the Autism Awareness Month is still on. And, whoever I talked to said that you have taken this topic in a very relevant way forward. Thank you for introducing the subject also. And we have to now burst the myths, as our concept of this webinar is the reality and the ray-busting myths. Now, iSOPARB has joined hands with Neurodevelopmental Chapter. Thank you, IAP, also for joining in this venture of ours. So I extend my warm welcome to all the learned faculty here, Dr. Sulekha ma'am, Dr. Mala, Dr. Pandey, Arup sir, and we have Deepika Deka ma'am, we have Dr. Harsha Khullar, and Dr. Pragya Mishra is expected to join us soon. All the learned speakers, panelists, and chairperson. Welcome, dear all. So I will first request Dr. Sulekha ma'am to shower us with her blessings. Dr. Sulekha Pandey ma'am is the ex-professor and head department of OBGYN at Institute of Medical Sciences, BHU, Varanasi. And she initially has been ex-professor and head UCMS Nepal also. Currently, she is the director Srishti Fertility Clinic and consultant Apex Super Specialty Hospital. Madam has been national vice president iSOPARB 21-22, and currently she is the she's the president-elect National iSOPARB 2025. Over to you, Sulekha ma'am. Welcome once again.
Thank you very much, Dr. Anita, for your nice introduction. I am really very much honored to be the chief guest on this prestigious topic, autism. Now, this autism awareness campaign, we are not hearing for a very long time. During our time, we used to think these children have some mental abnormality. But slowly it has come that it is autism spectrum disorder. It is a lifelong developmental disability. It is. Pardon? Can you hear me?
Yes, ma'am. Audible.
Okay. So my good evening to everyone, especially all the senior members of iSOPARB, and they are Dr. Harsh, Dr. Mala, Dr. Veronica, the speakers, the Arup Maji, Dr. Pragya, Dr. Anita, and all the members of iSOPARB, whether they are the senior members and all the junior members and all the members of Delhi Society of iSOPARB. I'm really greatly honored to be the chief guest on this prestigious topic of autism. Now, autism spectrum disorder is a lifelong developmental disability characterized by changes in the social behavior. They have restricted interest, and some of them may have physical disability also. And we still don't know what is the cause of autism. And now there are all excellent speakers who will tell us all about it. What is required is a right support, early intervention, friendly environment, so that these autistic children can have a normal life. I welcome to all the members who have gathered here, all the eminent speakers and chairpersons who have participated in the webinar, and all the organizers who have organized this excellent topic of autism. I hope this will help all of us to identify early intervention and support these children to live a useful life. Once again, thank you, Dr. Mala, and for inviting me in this webinar, and all the speakers. I'm sure without wasting time, we should proceed to the speakers. Thank you once again.
Thank you, Sulekha ma'am. Thank you for those lovely words of wisdom. We are honored to have you all here. So I think we can start with lighting the lamp of knowledge and the Saraswati Vandana to seek blessings of the Devi of wisdom, that is Saraswati Ma. You can play the... Can you make it louder?
Cannot hear, Rajni.
The audio is not there.
Ajay?
Not audible.
Yes.
Not at all.
Ajay, are you there?
So
What not there?
it was not audible, but may Lord Saraswati bless us all with the knowledge. So, with the permission of seniors, can we go ahead with the scientific session now, Mala?
With permission of Dr. Sulekha Madam and Dr. Arup Majhi Sir, we can go ahead.
I think we can go ahead.
Okay. Thank you, Arup sir. Thank you, Sulekha ma'am. Now, the first speaker of the scientific session is none other than Veronica Arora herself. She's the consultant. Can we display the CV of Dr. Veronica again? She's the consultant genetic and genomic department of Sir Gangaram Hospital, New Delhi. And she is going to talk on genetics and prevention. The chairpersons for her are Dr. Harsha Khullar ma'am. Dr. Harsha Khullar. CV of Dr. Harsha, please. Yeah. Dr. Harsha Khullar is MD FICMCH FICOG. She is the President-elect iSOPARB North Zone, past President iSOPARB Delhi branch, and ex-member of Foxy Breast Committee and has been Vice President of NARCHI Delhi branch. Ma'am has got special interest in oncology and she has been past President of DGF Center also. She has held various worthy positions in various organizations. And the other chairperson is Dr. Chandra Mansukhani. Please display the CV of Dr. Chandra Mansukhani. Dr. Chandra Mansukhani is the Vice Chairperson, Institute of OBGYN, and she has got special interest in adolescent health. It was a pleasure working with her for adolescent health at various platforms. She was immediate past President iSOPARB Delhi Chapter 21-24, recipient of APJ Abdul Kalam Award, and she has been chairperson MTP Subcommittee DGF Central 23-24 and editor of AOGT Bulletin 2022-21. So many accolades to her credit.
Thank
So,
you, Dr. Anita. Thank you, Doctor. I think we can proceed for the true topic because we are waiting to listen Dr. Veronica. And she's going to cover a very, very important topic. So I think we should move on to the main topic. Dr. Veronica, you can, I think, don't need any introduction. And please, yeah, ma'am.
I think before
Dr.
that, I
Harsh,
must
ma'am.
thank Dr. Before that, I must
Harsha
thank
ma'am is
Dr.
there.
Anita for
Welcome,
introducing
Harsha
me.
ma'am.
Thank you very
Welcome.
much. And I think very good evening to everybody. And I think Veronica has chosen a very good topic of autism. And you know, at almost, I was just looking at the statistics. In India, the prevalence of autism in children is around 1 in 68. That's very high. And secondly, that boys are affected more than girls. I don't know the reason, but I think Veronica is going to discuss on that also. Because why this thing boys are affected most with the autism.
Yeah.
Dr. Veronica, please. I think she has already been introduced by Dr. Anita. So she's a very good speaker, Veronica. So Veronica, you can proceed with your presentation.
Thank you so much. Thank you, ma'am. So I'll just dwell right. Can you hear me?
आज मैंने ऊपर का कमरा कर दी मोटी मोटी छोड़ के चली गई तो मैंने घर ये प्लीज आईफोन 2 जो है प्लीज अपने को म्यूट कर लीजिए iPhone 2 please mute yourself. Thank you.
Right.
Over to you, Veronica.
Yes, ma'am. Just 1 second. Trying to share. So I'm going to be talking about the genetics and the prevention of autism.
Yeah.
So, what do we do when we have a couple that comes to us with a child with autism, and secondly, if they do not want to have a child with autism? So we are going to just touch upon a autistic child, if the disorder is treatable, and some cases with messages that What do we do when we find such children? So 50 to 70% of autism is of a genetic origin. Now, of course, we also need to note that everything that is genetic does not run in families. There is a difference between genetic disorders and familial disorders. So 50 to 70% of autism is caused due to some aberration in the genomic structure of a cell of that individual, but that is necessarily not hereditary. It can be prevented in the next child once the cause is identified to be genetic. So, the first thing that we do when we have a couple who comes to us with autism is evaluating the child. Then we go for genetic testing of that child, and once the genetic cause is established, then we can go ahead and, with the help of our obstetric colleagues, go ahead and offer prenatal diagnosis and prevent the condition in the next child. So important here is that if in a family a child has autism, testing can never be directly done for the next child, and the first and the foremost thing would be to test the proband or to test the autistic child themselves. So the genetic tests in autism can be varied. We always start with the test for chromosomes. The conventional test for chromosome has been a karyotype, which is a graphical representation of all the chromosomes in the descending order of their size. And we look at the karyotype or chromosomes with our naked eyes inside a microscope. Because this is a very user dependent test, it is not a very sensitive test to pick up abnormalities of the chromosome. The only thing we can pick up is that if there is a whole extra or a whole missing chromosome. So we have other tests that we can do which are for autism, which are better than karyotype, is the chromosomal microarray. So chromosomal microarray is the test of choice in autistic children. It looks at smallest deletions or smallest insertions and duplications which are missed by karyotype. If we can look at the picture here, in this test, it is a DNA based test, so it's more accurate. So in this test, we have patient's DNA and we compare it to the reference DNA. Whenever there is some part of the chromosome that is missing, there is a red signal that the chromosomal microarray gives, and when the part is extra, it is a green signal. So based on this, we can actually identify if there is a micro deletion or a micro duplication. So this is the first test to be done, of course, except when we already know that we are expecting some disorder which is not going to be picked up by microarray. So the genetic changes, as I spoke, could be a chromosomal change like Down syndrome, an important cause of autism. So karyotype, if done, will remain an important test. So now chromosomes have genes which are present on them, and the genes are present like a pearl of necklace, and the genes contain some letters like the A, T, G, C in tandem. And if there is any mutation or if there is any change in these letters, that can lead to non-functioning of that gene. And this non-functioning of is not detected by the karyotype, but by an exome sequencing test. So we go ahead in a child with autism and first do the chromosomal test called chromosomal microarray, and then come to the test for genes. Now let's come on to the burden and why such testing is important. The prevalence of autism, there are varying figures everywhere, but approximately 1 in 50. We go on talking about Down syndrome and testing for Down syndrome and making it universal when that prevalence is much lesser, maybe 1 in 800. So autism is much commoner than that. But unfortunately, we don't have a good test in pregnancy to pick up autism as confidently as we have our combined first trimester screening or NIPT for Down syndrome. And for this reason, we are not able to do targeted testing in pregnancy. So there are many opportunities which we have to prevent and to Ajay, can you please mute?
Mr. Shivank, please mute yourself.
So there are
Thank you.
numerous opportunities that we have. The first is early diagnostic and intervention, which Dr. Praveen will be dwelling into. Personalized medicine means that if we identify the real cause of autism, we will treat them better. For example, we treat a fever better if we know it is caused by a typhoid or a TB. Then we understand the spectrum. A child with a mild ASD can maybe go and attend a normal school, and that is better for him than a child with severe autism spectrum disorder who will benefit from having special education. So important to understand that there is a spectrum and we cannot just label it as autism and move ahead. Having a diagnosis helps in family planning. It helps in telling the family that this disorder can be prevented in extended members as well. Risk assessment in siblings, having a community of support for autistic children, even for normal children and mothers and fathers, having someone to support, having a community is important, and this is much exaggerated in the children with autism. The etiology of autism spectrum disorder ranges from genetic to environmental. Genetic on one side and environmental on one side. There is a lot of genetic heterogeneity, means that we don't have just one gene, we have multiple genes with multiple patterns of inheritance, and there does exist an overlap between with the environmental causes. For example, a prenatal, perinatal, or a postnatal insult can result in autism. We have limited information on the infections or vaccines causing the same. The autism spectrum disorders are more common in boys due to multiple, are more commonly identified, I must say, in boys due to multiple reasons. One, of course, that sometimes boys are brought more to attention, they are brought more to medical care for obvious reasons in our country. Number two, that there is something known as a threshold liability, that is the amount of genetic mutation load that is required for an autism to be occurring in boys is much lower than in girls. So the amount of mutation is lower, so if that happens, the boys do get autism. Is there always an overlap between the genetics and an environmental condition? No. There is a group of autism spectrum disorders which are purely genetic, and those are the ones we can go ahead and prevent in the next family. The genetic testing benefits I have already discussed and alluded to. So when we have a child with autism, we take a complete comprehensive history in the genetic clinic. We ask for the medical perinatal issues, history of any teratogen drug intake, the developmental milestones. The motor milestone more or less will be fine. The child will be sitting, standing at the right age. But the major milestone that will not be okay would be the cognitive social milestones and the speech. There will be a significant speech and the cognitive delay in a child, loss of eye contact, loss of stereotypic behavior. Presence of stereotypic behavior. Next, in every case where we suspect a genetic disorder, we take a family history, go up to the third generation, that is the great grandfather. After taking a history, asking for any seizures, asking for any neurological deficits or any abnormal tone, we go for the physical examination. And in the physical examination, most important is the head circumference. If the head circumference is much lower, there is microcephaly, we deal with a certain group of genetic disorders. But in autistic children, we will find that the head circumference will be much larger. There are specific genes like P10 genes which will be more expressed in autistic children, and we have to look for those genes when performing the genetic test. We have certain neurocutaneous markers like cafe au lait spots and like hypopigmented macules or ash leaf spots in autistic children. So a complete head-to-toe examination should be done. Fragile X syndrome needs special mention. It is the most common cause of autism and inherited intellectual disability in male children, and that has to be looked for. So, happy demeanor, how is the behavior? All this gives us clue for diagnosis. Now, the testing part. Once we have done the history and the physical examination, we will go ahead and do the testing part. The most important test in autism are the ones related to metabolic disorders. And I say that because these are the ones which will benefit from medical treatment. So disorders like homocysteinuria, organic aciduria can present with autism. And if we perform these simple tests, so GLAX is a mnemonic that we use in genetics that stands for glucose electrolytes, lactate, ammonia, and potassium, which stands for all the electrolytes and the ketones. So if we do the GLAC and we do homocysteine and fasting amino acids, organic acids, and TMS, we will get hold of a lot of treatable autistic conditions. So these conditions, if identified early, can prevent a permanent or a irreversible brain damage. We have discussed the test. So that's the first line of test for autistic children. MRI to be done only if the head circumference is in the microcephaly or the macrocephaly range. The genetic test, the test of choice is chromosomal microarray. If that is normal and we have a strong suspicion of a or genetically inherited autism, or they want a prenatal diagnosis, you do the gene related test, that is exome sequencing. So this is the summary. In boys with autism, the test to do is Fragile X, because it's an X-linked disorder, will present only in boys, and chromosomal microarray. And girls, we do chromosomal microarray and exome sequencing. So I just present some 5 very quick cases with one message each to tell us that if we test children with autism, what are the benefits? So first is the biotinase deficiency. So the message in this case is a missed vitamin that changed everything. Ara was a child who came to me at 3 years, had autism, delayed milestone, skin eczema, and frequent seizures. Genetic testing revealed a disorder called biotinidase deficiency, in which there is a simple deficiency of a gene, biotin gene, which makes the biotin protein. So just giving oral biotin supplements, which cost some 5 rupee a tablet daily, cured this child. The child did not have seizures, the skin improved, the speech therapy now became effective, which was not being effective for the past 3 years. So a missed vitamin did change everything. The second case is of a child, Meera, who's 2.5 years old, had normal development, and then the development underwent regression. And on genetic testing, there was a problem in the creatine transporter gene, a gene that transports the protein creatine into the brain. So now the treatment was done by creatine and arginine supplementation. This disorder is not very easy to treat, but slow and steady gains in speech and learning were shown when the creatine was given. So the takeaway was that metabolic therapy can support brain development. And so this child went from going into regression to now recovery by just giving some creatine, which like these boys are always taking for bodybuilding. The next is a common disorder for which we offer carrier screenings for couple before pregnancy also. It's an X-linked disorder present in boys. So Rohan, 4-year-old, presented with hyperactivity, a large looking head, hand flapping, and speech delay. And genetic testing by this test called PCR showed a Fragile X syndrome. And the child was treated with metformin and also with therapy. So there was a lot of occupational and a speech therapy given to this child along with metformin supplementation. And this helped in tailoring the therapies and empowering the family to prevent this disorder happening in other boys in the family as well. So we empowered the family by giving them this diagnosis. The next case was a Zoya, a child who was 6 years old. She had seizures daily and autism and poor attention. So on genetic testing, there was a deficiency of a glucose transporter. So glucose was not reaching her brain. So brain was not obviously working without glucose. That's why the treatment of this disorder is by ketogenic diet. So ketones were given to her instead of glucose. So they passed to the brain and her brain started functioning. She became seizure free and there was a major improvement in focus and learning. So this little change in the diet did change everything for her. And finally, there was a child who was 18 months old. Irritability, poor eye contact, developmental delay, and the diagnosis showed that there was a deficiency in the FOL-R1 gene variant, and a folinic acid therapy helped the child, and there was marked improvement. So we did help these patients by making these diagnoses, and these children also really did improve. But are all the genetically associated autistic disorders treatable? So unfortunately, no. A small percentage of them are, but still it is our responsibility to check for those. So we go ahead and now see that if we have a genetic diagnosis and it is not treatable, can we prevent them? So this should be V. So we can prevent these disorders in the next pregnancy by offering them prenatal diagnosis, testing at 11 weeks for that disorder. And if the family wants to not continue, they can decide to. If it is a chromosomal disorder, we can do a IVF with PGT-SR. If it is a monogenic disorder, we can do IVF with PGT-M. If the disorder comes from a father or the mother, we can use a donor and undergo IVF. So in this way, we can go ahead and prevent these disorders. So I'd like to again end my talk by highlighting the different benefits of providing every family with a special child with genetic testing, because now many targeted treatments are possible. We don't even have an idea and we go and check and the treatment exists. Once we have a diagnosis, there are better developmental outcomes. This prevents further brain damage. It does save a lot of money, time, and most importantly, guilt of the parents that if they did something that made their child autistic. That feeling of that I did my best for the child is huge, and it gives them a lot of emotional relief. Finally, it also gives them the benefit of joining support groups and getting in touch with experts throughout the world for that diagnosis and helping them to maybe give a better life to the child. So healing starts with awareness. Let's get together and get aware about the genetics of autism and spread the word as well. Thank you so much.
Thank you, Veronica. Over to chairpersons for their comments.
Yeah. Thank you, Dr. Veronica. It was a beautifully described lecture, and you covered all the areas of the autism, and you really beautifully described each and everything. Because I was aware that we diagnose the autism by exclusion, but you increased. I think everyone autism has, in some cases, there is a cause and we can treat them. That is a one thing. And you explained beautifully, very well. And you covered all the things. So I think every child should be evaluated well by an expert person so that we can plan the treatment for that particular child of the autism. Thank you, Dr. Veronica. I think I would like to request Dr. Harsha Kullar also to give her expert comments.
Harsha ma'am?
Ma'am, are you around?
So if Harsha ma'am is not around, anybody else will like to make a comment? Sulekha ma'am, Arup sir, anybody else?
Dr. Veronica, it is a wonderful talk. And a little query that I have is, now sometimes we have seen some of the children who are mildly and they have everything normal except that they don't want to mix. Their socially they keep themselves aloof. So how do you manage those girls or boys?
Yes.
Otherwise, they're very intelligent.
Yes, ma'am. So, ma'am,
And
mostly they will not be having a genetic. Yes, ma'am.
Is it very intelligent children, but on investigation, it comes as autistic spectrum. Only problem that we see that they keep themselves socially away. They don't like to mix with children, and some eating disability or something they have.
Right. Yes, ma'am. So, ma'am, what you're describing, in most cases, such children don't turn out to have a genetic cause. And the managing part, I think Dr. Praveen, madam, is here to comment on it.
Yeah.
So,
Yeah. So we'll be discussing, ma'am. We'll be discussing it in detail about about the autism in my lecture. Yeah.
yeah. So thank you, Dr. Praveen, and thank you, Dr. Sulekha, ma'am.
Doctor-
Same is the case with the variant which, comes to the diagnosis in adulthood. So there may be subtle changes,
Anita, one
subtle
question.
signs. Yeah,
Dr.
Chandra.
Anita, can I?
Yeah,
Dr.
yeah.
Veronica, I would like to know that in how many patients we don't find any cause.
Actually, ma'am, so we don't find any cause. We are a referral center, so we are
Yeah.
definitely have a referral bias. तो हमारे पास refer ही हो रहे हैं जिसमें it's likely to be genetic. So we do find a cause in approximately 60%.
Okay.
But that may be a referral bias.
But as far literature goes, Dr. Chandra, almost 20 to 30% cases you find the genetic cause. It is a mixture of genetic and environmental factors. So it is a multifactorial thing. So
Yeah.
as per literature, almost 20 to 30%.
So whenever there is an environmental factor, so I think they get improved.
It's not like that. It is a genetic does not mean that every child will show genetic. There is a genetic predisposition in these children.
Absolutely.
It's something like I have diabetes. So there is a genetic predisposition. So even if I don't take sugar, it will not go away. Isn't it?
Yeah.
So, but if you remove the environmental factors like excessive screen watching, excessive, the child is not interacting, despite that, child will not be making eye contact. I will be discussing basically, as Dr. Sulekha ma'am was saying, these children have a problem with social interaction and social communication. Autistic children are intelligently good. They have good intelligence. They can hear well. They can speak well. They can do most of the activities on their own. The major concern is social interaction. They are not interested in interacting with people. They are more interested in objects. So that's how their learning gets affected. They do not learn cognition and speech as much as if they would have been interacting with the people. So first we have to understand the basis of autism, then we'll be able to help them why it is happening.
Absolutely, Chandra.
Thank you, Dr. Praveen.
Absolutely, Dr. Praveen has made a very nice expert opinion, because we have seen families that first child was absolutely fine, and the second order child has a problem. So because the genetics is almost the same, maybe some environmental exposure was different. So you never know. These children need investigation. Arup sir, will you like to make a comment? So you have to unmute yourself.
Dr.
Yes.
Veronica has nicely presented and made us understand what prevention can be done, because autism is a real problem now. About 50 prevalence within the 50 to 60. It's not a matter of joke. So many the person, individual, the child is affected, the family affected, the society of affected. So I think that prevention is very important. So we'll now go to the next speaker of the pediatric neurologist for another important talk, that is the etiology. And Veronica, majority of the, not majority, but the significant number of the patients can be prevented, can be birth from the autism. And later on it can be managed also.
Thank you, sir. So with your permission, can we move on to the second session?
Yeah, definitely. We'll go to the next session.
So our next speaker is none other than Dr. Rajni Farmania. She's the senior consultant Pediatric Neurology, BLK Max Super Specialty Hospital, New Delhi. And she has multiple publication in Index Journal. I think she has got special interest in the subject, and she will be talking on pathways and etiology of autism. So our worthy chairpersons for this session are Dr. Arup Maji sir and Dr. Mala Srivastav. Dr. Arup Maji has been the past president iSOPARB. Currently, sir is the professor Santiniketan Medical College, Bolpur, West Bengal. Has been authored to very good books on obstetrics, bedside clinics in gynae, operative obstetrics. Sir, thank you for that beautiful compilation of the subject. And sir has been a former professor and head OBGYN at RG Kar Medical College, Kolkata, delivered multiple orations, numerous guest lecture, workshops, and several PG classes. Thank you, sir, so much. Sir has been president of Bengal Ops Gynae Society also, and president Kolkata chapter of ISOPA previously in 18 to 20. Sir has 30 years of teaching experience, examiners to many UGs and PGs and DNB across various universities. So many publications to his credit in national and international journal. Thank you, sir. Thank you for the honor. You have joined us today. And our other chairperson is Dr. Mala Srivastav. She is the head of gynae oncology at Gripmar, that is Gangaram Hospital. President Narchi Delhi chapter 24-26, Vice President ISOPAR 23-24, and she has been past president of AOGD also between 20 to 21. She is a dear friend, and her main areas of interest are gynae oncology, gynae endoscopy, robotics, and whatnot. She has received so many awards and accolades. So if I start reading, the whole time will go. So I think Mala, you can introduce the subject and invite the next speaker. That is Dr. Rajni Farmania.
Good evening, everyone. Yes, yes,
Thank
sir.
you, Dr. Anita, Dr. Mala, Dr. Veronica, and Madam Sulekha Pandey for inviting me. Very, very, very prestigious session of autism and very important topics. Veronica has presented very nicely. Veronica, thank you. Now I request Dr. Rajni Farmania, who is a senior consultant pediatric neurology, a very important topic we will hear from him, the pathways and etiology of the autism.
Thank you, sir, for giving me the chance to speak on the topic. And I'll be sharing my screen now. Am I visible and audible both?
Yes, yes, you are visible and audible both.
Thank you. Thank you. So thank you to the esteemed chairpersons and the organizers to invite me to speak on this topic. This is a kind of core pathology and core genetic based topic which has been given to me, but I will try to put some clinical inputs into it to make it more relatable and not just go into the basic neuroscience. So there's a lot about autism happening, and maximum research on autism is in last decade or so, maybe last 2 decades, and the advancement is exponential. So like what we have done in last 10 years, maybe in next 2 years, we'll be doing more than that. And there is a lot which is coming up in terms of biomarkers and management strategies. So let us have a glimpse on the etiology and pathways of autism spectrum disorder. So the only word which fits in autism and which fits the most in autism is complex. So you read the genetics, you read the clinical thing, everything will be, the first word will be complex. So it's a complex neurodevelopmental condition which has challenges with interaction, communication, and restrictive or repetitive behavior. The etiologies we all have been till now discussed that it has genetic and environmental, and epigenetic is another term which I've introduced, and a neurobiological component. So let's have a little history about it. In 1911, Swiss psychiatrist Eugen Bleuler, he first coined the term autism. So it had been taken out from the word schizophrenia for the patients of schizophrenia, which just means into the self, like a withdrawal phenomena, which is sometimes seen in schizophrenia. So with that word, that autism came out in 1911, a very nascent word. In 1943, the main work which has been done in autism was Leo Kanner, and he published a series of 11 children who displayed the strong desire to stay alone. So sameness in the 11 children, and he said as infantile autism. Now, in 1943-44, there was another pediatrician and psychiatrist. He was a pediatrician actually, Hans Asperger, and he published a paper on autistic psychopathy in childhood, and he said that these children have a different pathophysiological phenomena, and they need to be a different entity for this. So initially, when I told the story about 1930s, 40s, the initially coining of the term, but what led further is that why does this happen? And then in 50s, 60s, the term of refrigerator mother theory came. There was actually a paper in 1949 by Kanner itself, who coined the term like because of the refrigerator mother model, the mother or the family is not so does not have so much of bonding with the child, and they don't have the emotional bond, they don't do the emotional stimulation, and that is why that might be the reason for autism. And this actually created a backlash to all the mothers and families, and there was a lot of unrest due to this. So by refrigerator mother theory, it was a cold and unemotional parenting. By 1970, the more scientific data came up on this. So there was a very important paper in 1977, which was on 21 same-sex twin pairs. So this was a landmark study. So genetic study on 21 twin pairs, monozygotic and 10 dizygotic. And what they found was 36% pair was concordance rate for autism in monozygotic pairs compared to 0% in dizygotic. So this clearly showed the world that it has a genetic basis. It is not the emotional environment, it is not the refrigerator mother or the other thing, but it has a genetic predisposition. This was the first landmark paper on that. And not just the autism, they also checked the cognitive abnormalities in the children, and then they found the cognitive abnormalities was 82% in monozygotic pairs. So there was abnormality in monozygotic twins compared to only 10% in dizygotic. So this clearly laid the foundation for more geneticists to work on it, more research going on this. Now, gradually, the evolution in 1980s and 1994 was on diagnostics. That how do we diagnose and say that this child is autistic and this child is not? Because it will ultimately lead to the difference in the prevalence which we see in different cultural settings. So then came the diagnostic evolution and autism spectrum by the American Psychiatric Associations. So initially, it was called childhood schizophrenia, and then autism was given a specific entity that it's a developmental disorder. And then there was a PDD term, which was given in DSM-4. And then finally, we knew that autism is not just one set thing. It is a spectrum. It can be mild, moderate with multiple variabilities and comorbidities. What makes an autistic child different from the another one is multiple comorbidities. The etiology. So it makes one child different than the other autistic child. So now coming to the basic of etiology, why does autism happen? And this is an enigma. Still now it is an enigma for all the parents. I see a lot of OPD patients, and not all, not leaving a single one, all will ask कि मेरे बच्चे को ये क्यों हुआ है? Just tell ma'am, have I given more phone? Or have I exposed the child to the screen early? Or मैंने इसको ध्यान नहीं दिया? That refrigerator mother theory is still prevalent socially. I would ask Dr. Praveen also to say on this. I think so she'll also agree that still now this social background thing is going on. It's about the environment, but more of it is a genetic predisposition. They have a genetic soil on which the environmental factors matter. So there are number of genetic mutations. It can be single gene disorder, copy number variations, single nucleotide polymorphisms. Then there is a epigenetic modifications. In this, there is no DNA change, but then there are three mechanisms which we'll deal in further slides, that which actually changes the gene expression. And then there is a sex differences, which we were discussing just before this, that why does male have it? Male to female ratio is 4:3:1. So there are multiple theories on that there is a female protective effect, sex chromosome gene dose, which Dr. Veronica was also speaking, that females need a more probably genetic dose to manifest as an autistic character. It has something to do with sex hormonal levels or because of the gene expression. Basically, sex hormone may decide on the gene expression in the male versus the female. So new researchers are still coming up on this, and still the enigma is yet to be unfolded. And then the big chunk is environmental factors. So what's the difference? To explain it better, I would set with an example. Suppose we have two kids with the same genetic predisposition, but one child will get the prenatal exposure of maybe environmental toxin or a medication like sodium valproate or any other birth related injury. So that child is more predisposed to have autism spectrum disorder clinically compared to the child B who did not had any environmental factors. So there is a soil of genetics and then it has an environmental factor on it. And then this circle moves with the severity of presentation. Some children will have more social communication issues. Some children will have more of a repetitive behavior. Some children will have more of sensory issues. So this amalgamation of the clinical profile is also not uniform between autistic children. And in this also the environmental factors play a role. So genetics plus environment, both of them will ultimately lead to abnormal neuronal development, maybe structurally and more so functionally, because in most of these cases MRI is normal. If we try to find out that MRI shows some structural problem, maybe not, we will not be able to find it, and it is more at the functional level. So twin studies play a very important role. The heritability is around 64 to 91%. This numbers are very variable, around 40 to 80% also in some studies. So in families, what we have seen is autism recurrence also happening. So there are many families who have both the siblings, not just the twins, the first child and the second child, both might have the autism features. So it is more so when you have a male, first child male newborn, and it is less for the female. Male is to female, we have already discussed, it is more common in male due to multiple factors. And it's an extremely complex genetic pathophysiology. The genome-wide associations, there was one I found out on STRI, there was around 1,200 genes and genomes which have been identified with autism, and still more and more numbers are added. So SNP is single nucleotide polymorphism and CNV is copy number variations. And there are other intronic region mutations also associated with autism. So when we say the genetic architecture, we want to understand that how it is inherited at the same time. So autosomal recessive, there are a lot number of lists, autosomal dominant and X-linked. So autosomal recessive, when the boy and girl, 25% chance of recurrence in the siblings, and then you have multiple genes associated with it. So there was just a term by the chairperson in the last visit that diagnosis by inclusion rather than exclusion. So the general belief is that we diagnose autism by exclusion, but there are cases where we diagnose autism by inclusion and we go ahead with the genetic testing. So let's see an example. He is a 9-year-old boy. He was diagnosed with autism spectrum disorder at the age of 3 years. And his birth history was uneventful. He was a well child, G1P1. He had mild global developmental delay, started walking by around 1.5 to 2 years, and he had speech deficit and communication deficits. He had his first seizure at the age of 3.5 years. That was with mild fever. And then by the age of 9 years, he had just infrequent 4 seizure episodes. And then when he came to me, he already had done an MRI brain, which was normal. He had an EEG record, which was an awake record. But by norm, when we see these children with epilepsy, we do the EEG in a sleep state because there are chances of epileptic discharges getting potentiated in sleep state. So sleep EEG is must in children with autism spectrum disorder. And this is another indication to get an MRI done. So Dr. Veronica has said that the small head size and a large head size, both are an indication for MRI. Epilepsy is another indication where we get an MRI done for these kids. And the third one is when the children do not have development in place. Like in general, autistic spectrum disorder kids, they have motor development at least in place. when these kids do not have a motor development in place or they show deficits in motor development also, we go for MRI brain. And this child had EEG, which was bad, kind of electrical. It was a epileptic encephalopathy. And then we went ahead with the genetic testing also. Not a very specific dysmorphism. The geneticist in-house would know that there are very subtle dysmorphic features. And then when we got this report, it showed a CNV, the copy number variation of 22q13.3 deletion syndrome, which is a Phelan-McDermid syndrome. And then we obviously can prognosticate the child for epilepsy. We are still treating symptomatically and he's doing good in terms of epilepsy, but yes, he still has his own challenges because he's going towards the adolescence currently. So this is another child. She's also 10-year-old girl. She had global developmental delay, started walking by around 2.5 years. And she had autism spectrum disorder. She had hyperactivity. She had intellectual disability. She still has intellectual disability. Basically, she had sociocognitive domain or poor learning at school. And then currently now she has intellectual disability as well. She had seizure onset pretty early. And then it was very frequent to at least 2 to 3 in 7 to 10 days. And currently she's on 4 season medicine. So she has a drug refractory epilepsy. Genetics was advised and she was 15q deletion. I don't have the genetic report right now, but she's a 15q deletion syndrome. And then again, we diagnosed autism by inclusion, not exclusion, because we have some atypical features. So autism can be seen as a syndromic approach, a syndromic autism or a non-syndromic autism. In syndromic autism, they will have a motor delay, kind of motor global developmental delay, doing slowly, everything slow, and then finally having autism feature plus minus epilepsy. So these group can be clubbed into a syndromic version where we
strong action will be taken against them. Punishment will be significant and stringent, which these terrorists.
Suman ma'am, please mute yourself. Suman ma'am, thank you.
So syndromic autism will have some atypical features for autism. The idiopathic autism group or the non-syndromic group will have, they are generally good by IQ, they will have normal motor delay, normal motor development, and they just have deficit in social and communication. This non-syndromic or the idiopathic ones are the bigger lot, and this genetic ones are just 20-30% to our plate. So these are other genetic disorders. This child has Angelman syndrome, happy demeanor, bushy eyebrows. And this girl, I'll show the video. This girl is a 5-year-old girl and she has this hand wringing movement. She has autism and she has this hand wringing maneuvers or hand wringing stereotypy, we would say. And then we did an EEG. EEG had generalized and very high burden of spike wave discharges in sleep, diagnosed as MECP2 positive and Rett syndrome. This third person is this third boy is a 4-year-old boy with large ears and a macrocephaly, which we are not able to appreciate here, but yes, ears we can see very characteristically. So this is a boy with Fragile X syndrome. So these are the cases which have some clinical clues where we work up and understand that they have a genetic basis to it. So genetic variations, one which I showed in the single gene mutation, and then there is a CNV, it can be missense mutation, nonsense mutation. There's a long list at everything, at every channel where we can see. The de novo mutations in CHD is also very common. SCN2A is common. SYNCAP1 also, we have refractory epilepsy. So I have 2 kids with SYNCAP1, 1 with green2B. So all these kids who have autism-like features will have developmental delay and seizures as well. So what they do, what does this genetics do? It ultimately leads to disruption in neuronal proliferation, migration, differentiation. So they have something to do in the structure and function of the neuronal system. They have synaptic dysfunction. They have dysfunction in the, they have imbalance between the excitatory and inhibitory neurotransmission. So glutamate and GABA neurotransmission is haywire, and they have something to do with neurotransmitter systems. So here, this cartoon says that there's a dysfunction in signaling pathway with multiple factors, which we can see, and with multiple receptors. And there is an imbalance between E is excitatory and inhibitory pathway in autism. There is a defect in synaptic, post-synaptic density and its communication, and mitochondrial dysfunction. So finally, when all this, so mitochondria is related to the energy and to the oxidative pathway, it will lead to maternal immune activation. So oxidation and inflammation will ultimately lead to the genetic basis for autism spectrum disorder. The most recent research in terms of etiology is gut-brain axis. So we all know our gut is our second brain because we have our autonomic nervous system or the enteric nervous system in that, and the gut microbiota, the good bacteria, everything in health, weight loss, inflammation, autism, mental health, everything is about gut-brain axis. So this is a very, very high burning topic in autism in terms of etiology and also in terms of therapeutics. So what does it do? There has been research where it showed that if we
अभी ना ये सेमिनार बहुत जरूरी है
if we transfer the microbiome
इसको भेजियो मत अगर कोई आएगा तो वैसे बता
if we transfer microbiome from an autistic child to a mice, a normal mice, this mice will also show features of autism. So something has to do with gut microbiota and genetics as well. So infection, any diet imbalance or genetic dysvariation can lead to dysregulation of the intestinal homeostasis, and these are the various treatment methods. So what happens? There is a disruption of intestinal barrier. So neuroinflammation. So again, there is an inflammation and all these neurotransmitters, they will have a hodgepodge in that. There is an imbalance. There will be decreased serotonin, decreased GABA, glutathione is decreased. So all of these will lead to release of neurotoxin and inflammation. So gut is affected, nervous system is affected through neurotransmitters, and it will lead to all the behavioral issues in children with autism. In fact, this is the same theory which is being used by the psychiatrist for adult population also, in depression, in anxiety. Also, they try to fix the gut first, and then they try to fix the brain the next. So environmental factors, these are the common ones like maternal infections, drugs, toxins. Not much is known about the toxins because pollution, somehow heavy metal, there will be some case reports, not a very detailed and kind of robust data on the toxins and like pesticides and pollutions, which can lead to ultimately maternal oxidation and inflammation. Maternal metabolic conditions have been related, not a very strong kind of percentage numbers we'll have on this. And birth complications and prematurity obviously is an environmental factor or a high risk factor for autism. So prenatal exposure, this is a list. Postnatal exposures, again, vaccinations, that measles vaccination theory is out. It is actually not implicated in autism. But yes, then we have the mode of delivery, the infant feeding method, the stress. These are just the postulated ones. So epigenetics is another new term which I would like to introduce, because it is a study of how environment and other factors, it can influence the gene expression. So genetic makeup, or if you do the genetic study, maybe you'll get everything normal, but it focuses on the expression of gene. So it regulates the gene activity through modifications to the DNA and associated protein, and it will not change the DNA sequence. So there are three things to this. One is DNA methylation. That means adding methyl molecule to the DNA and altering the expression. Histone is a protein which actually binds. It's a packing material for the DNA. So if there is a histone modification, again the gene expression will change. And one is non-coding RNA. This will implicate on the protein modification. So again, a very complex diagram. Just we know these three terms: gene expression can be modulated by these three methods. The epigenetic method, the epigenetics is there beyond genetics to understand that. So again, laying an example on this, suppose we have two kids, both have a SHANK3 mutation, and one has a epigenetic mechanism which is on, which causes increased methylation in the promoter region, and it will lead to altered protein, and the child will have frank features of autism. The child B who has SHANK3 mutation in-house, but the epigenetic mechanism do not lead to increased methylation in the promoter region, and maybe this child will not show any feature, will come out to be typically developing. So same genetic mutation, but this epigenetics will decide that which child will have the presentation. So what are the future strategies? The behavioral therapies obviously is on. So new research is on brain stimulation also. Can transcranial magnetic stimulation help the cortical excitability? So these are new research pipelines. And transcriptional regulation, the excitatory and inhibitory balance, the gene therapy people are talking about on that. Neuropeptide is again to do with neurotransmitter modification and immune modulators. So what are the key messages? That autism is a complex interplay of genetics and environmental with epigenetic modification. There's a lot of genetic heterogeneity, and research is going on. We are expectful that we might get some good news for all the parents in maybe next 5-10 years, and we have more to offer to them. So thank you all.
Thank you, Rajni, for that wonderful presentation. It was an eye-opener for all of us. Dr. Mala, over to you.
Yeah, excellent presentation, Dr. Rajni. You nicely told about the genetics as well as the epigenetic aspect of autism, which we thought, as Dr. Chandra said, it was a diagnosis of exclusion. But
That
definitely,
I
we
really
have,
liked about your
yes,
line.
basically, we are also getting aware of this condition because we are not dealing with children on a day-to-day clinical practice. So, but we should know about these conditions and we should be able to guide our mothers, young mothers, regarding these genetic problems. Normally, we think that the child is shy. Maybe they will grow up, they will become normal. But if we can diagnose them early, catch them young, maybe we can prevent many future disabilities with the child and the family may be able to feel. So definitely, you have given a great insight among this condition, which is not so rare in our environment. So we should be, as healthcare workers, we should be aware of the condition. We should know about the preventive strategies, and of course, we can pass on the benefits of this knowledge to our patients in our day-to-day practice. Definitely, it's a multifactorial condition, and we should look into the matter with that point of view. Thanks, Dr. Rajni, for your excellent
Thank you,
scientific presentation.
Dr. Rajni, for wonderful presentation. Really, the etiology is very complex, and I think the prevention is much more difficult.
So what I would say from my experience is when I see a family with first child having autism and I ask about their further plans for next pregnancy, most of them are scared of second pregnancy. We don't want another. And then when I say this is your like fertility period and then you should try for it because this is a lifelong disease, they consider this as a project. ये एक बार बोलने लगे, ये एक बार ये करने लगे, स्कूल जाने लगे, then we'll plan or something. So we in house as a group, we all should actually help the families for the next pregnancy with proper genetic guidance, with geneticist in house with us to explain that yes, this there is a risk, but still we should try for a better and typically developing children, and we should almost work with these kids also.
Thank you, Rajni. Arup sir, your expert opinion. Please unmute, sir. Arup sir, please unmute.
Excellent presentation, Dr. Rajni. And she is herself expert. Rajni has so beautifully presented all the things Dr. Mala has described. One common question asked to us, particularly obstetrician, when one child becomes autism, the common question is whether the next child will suffer or not. That how will tackle. When you have said that 15 to 25% there is a chance of recurrence. How can we say actually? There are so many investigations are only from history taking and examination. This
So
is one question.
as Dr. Veronica said that we have to diagnose the proband. So first we should see the proband whether this child has some genetic etiology like a syndromic autism. If it is a syndromic autism, at least we can advise a prenatal testing. If it is idiopathic or a non-syndromic autism, then the chance of recurrence is explained. And I think Dr. Veronica the geneticist usually advises the couple carrier screen and then they go forward, explaining the risk that yes, we can go ahead, that we have not found as a syndromic cause, but still chance of recurrence is there and maybe they can advise for next pregnancy. So they should be properly evaluated rather than discouraging. So we should say them that please get this child evaluated and make up your mind that there are chances of recurrence, whether you want to take that risk.
Another question is very important to say. We'll have to face the all obstetricians. When one child suffers from the autism, the obstetrician is alleged that this is due to the birth defect. How can you safeguard yourself? Because environment is a factor definitely, but majority is not due to the environment. So how to safeguard the obstetrician, we will safeguard ourselves. That is very important. How? That is.
In the OPD, usually they ask me these questions कि जन्म की वजह से ऐसे हुआ या मम्मी को stress था. So a lot of things are actually related to autism. But then I tell that there is a no strong connection between that, and your investigations also do not point towards that. So it is not related to the birth injury or related to other things. Unless until there is a typical hypoxia, we do say
That is a
hypoxia can be
chronic hypoxia
antenatal,
may cause that.
not perinatal. It can be antenatal. So there is a lot to say for autism, especially, and we always try to safeguard our gynae colleagues because they also are not at fault. Nobody is at fault. It is difficult to diagnose in the antenatal period. Not all cases are picked up, and then when eventually the child turns out to be autistic, then if they have done some genetic testing, then genetic people are also in the plate. Madam, हमने सारे टेस्ट कराया जो जो आपने बोला फिर बच्चे को autism हो गया. So that risk and that enigma is there.
I'd just
Thank
like
you,
to
thank
add one more small point also, that the genetic tests that we at present have, of course, they cannot be completely comprehensive, sir, right? Because we are offering a basic battery of tests. So with those genetic testing, we have to say that there is a residual risk that is left because we have further genetic tests like a genome also. And we have new genes that are being discovered. So we can, with the current battery, cover only a percentage of genetic autism also. So that is one thing. And as Rajni ma'am, you mentioned about epigenetic causes, so I'm very happy to tell you all that Dr. Aradhana and I, we are hosting a national conference on the topic of epigenetic disorders. This is going to be focused and experts who will only be talking about that, so I invite you all to attend that in November. So we ourselves as geneticists will learn epigenetics. So it is a challenging aspect, but something that is next in line after understanding genetics. So I think obstetricians are the most excited people to learn and always gain the maximum knowledge. So yeah, so I think after
should learn.
yes, yes, sir. So thank you.
I think thank you, Veronica. So there is a question in the chat box. I think Dr. Praveen will deal with this in her presentation. So this is regarding a child extremely shy, picky eater, selective in wearing certain colors only, but academically doing well. Is it a cause of concern? So, ma'am, I request you to kindly, cover this question also in your presentation. Over to you, Veronica, for introducing ma'am, Dr. Praveen.
Yes, yes. Thank you, ma'am. Thank you, Anita, ma'am, for taking care of the sessions. And now we go on to the next session. So I will be introducing the chairpersons. Can I? Okay. So this is the session that we've all been waiting for, the actual management part of autism. And I am very happy to introduce Pragya ma'am. Ma'am is a consultant in infertility at the new Test Tube Baby Center in MGM Hospital and Private Limited, Patna. She has been the chairperson of Genetic and Fetal Medicine Committee (FOXY) from 2016 to 18. She's the Secretary General of iSOPARB 22 to 24 and has various awards and accolades to her name. Ma'am is also my senior alumnus from KMC, Kasturba Medical College, Manipal, and I am very honored to welcome ma'am today. The second chairperson today.
It's me, and I have already been introduced, Veronica. Thank you. We can carry it forward. You can.
Is the brainchild behind this webinar. Ma'am is the president of iSOPARB Delhi chapter and holds multiple accolades. She's one of the most enigmatic personality in Delhi in obstetrics, and very happy to welcome her today.
Thank you.
So welcome, ma'am, and I request you to introduce the speaker, ma'am.
Yeah. So Professor Dr. Praveen Suman is our next revered speaker. She's the Director Child Development Consultant, Sir Gangaram Hospital, New Delhi. She's going to talk on management of autistic child. This is a talk we are all eager to listen to. And ma'am is MD Pediatrics from Maulana Azad Medical College. So over to you, madam. We are eager to listen to you. She's looking after the she's the looking after the director, or she's the main brainchild behind developmental child consultations at Gangaram Hospital, if I know her well. So thank you. She's a developmental and behavior pediatrician, a very focused, and we are eager to listen to you, ma'am. Over to you.
Thank you, ma'am. Thank you, Dr. Nita, Dr. Veronica, the organizers, for inviting me for this talk. And it is always so nice to interact with gynecologists. I'm interacting with them after a quite long, after coming to development pediatrics. So it is such a wonderful feeling. And today, as our previous speakers have very nicely talked about the genotype and genetic and etiological factors of autism. So now I will be talking about the phenotype. How does children present and what we can do as a specialist? You can hear me? Is it okay?
Yes, ma'am. You are audible clearly.
So before going into autism, I will just summarize this. What does autism mean? Because as we have been explaining it as a very complex disorder, but when it comes to presentation, the most common presentation would be that child has a difficulty in social interaction and social communication. That means child is not interested in interacting with people. If we ask people, so generally they'll say अपने में गुम रहता है, अपने में खोया रहता है. So that's a general presentation that could, if we ask them, they will not come with this. They would be generally presenting with speech delays, hyperactivity, and other things, and behavioral problems, which are the most common manifestations or symptoms of autism. But this is not autism. Speech delay is not autism. A child with autism will speak fluently. So most of the time when they come, they are concerned that my child is not speaking. So I will start the speech therapy. And as soon as the speech therapy started, child speaking. But we don't see what he's speaking. He's not speaking meaningfully. He's speaking randomly something or the other. He is repeating whatever, echolele or... So it is not important to just speak. It is important to what to speak, when to speak, and whom to speak. That's what his social communication is. So, and the other important feature in these children is the repetitive behaviors, or they like to follow a certain pattern. They like fixation. So that's another important question, findings. There is a question in the chat box, and somebody has asked that my child is shy and is this thing and shy, and he's asking for the same color pattern. If it is there and it is affecting our day-to-day life, any developmental disorder, it is a spectrum. Even normal or typically developing people also have a different pattern. Every person does not have the same nature. It is a big spectrum. Similarly, in developmental problems, there will be a big spectrum. But we'll call it a problem only when it starts affecting our day-to-day life. So as per the question, if it is affecting your life, it is the child is throwing tantrum, child is showing a lot of behavioral issues which is affecting the day-to-day life, then definitely it needs to be addressed. So as we say, symptom becomes obvious over the time when social demands exceed the limited capacity of a child with autism. So initially these symptoms may not be much because the child is at home and not going out and with the parents. But as the child age increases and child is started going to school and environment, then these symptoms become more and more prominent. So unlike other developmental disorders, for which most of the doctors think jaise jaise umar badhega, everything will be fine, the autism features become more and more obvious and prominent as the age increases because it is related to the social interaction. But as a doctors, as a healthcare professional, all of us should be aware about the red flag signs of autism. The only important thing which we can do as doctors is we can identify early and start the early intervention. And by giving early intervention, we can improve the outcome of these children. almost 20 to 30% children can outgrow this problem if appropriate intervention can be given early in the time. So most of the time, these parents do not reach out for the early intervention because of multiple factors, because of stigma, because of they are not aware about the features. So as doctor, we should be aware that what are the common features which are present in the young age. These are the features like if a child is not responding to his name by 1 year of age, or has not started speaking any meaningful word by 18 months of age, or if he does not like to play with the toys appropriately. Most of the time parents at younger age would come that my child does not respond to name. So these a typically developing child starts responding to name by 6 months of age. If he's not responding by 1 year, we should be very cautious. And how does he play with toys? A child with typically developing will be playing differently with different toys, but a child with autistic spectrum would like to play with the toys inappropriately. I'll just show you some videos, and there will be a of interest and decreased interaction, and has odd movements and patterns or repetitive behavior. I'll just show you some, and he demonstrated echolalia. Echolalia means he just repeats the word. If you ask him what is your name, he would also say what is your name. So this is not speech. This is he's speaking, but he's not speaking it meaningfully. So that is what is called echolalia. So I'll just show you a few videos so that you become familiar with this is called, as you can see in this video, a child is playing with the toy. She's playing with the ring, but she's just spinning the ring. So this is not an appropriate. She's supposed to put it in the ring stand, but she likes to do it repeatedly, spinning the ring. Similarly, in this child, you can see this is called flapping, and he's showing abnormal body movements. So this is how children generally present. In this slide, probably you cannot hear the sound. Father is calling the child with his name, but he's not responding to the name. So when these symptoms are there, then we must be thinking about autism. So as I'm supposed to talk on the management only, so what is the limitation in the management is, there is, as I said, there is lack of awareness. Most of the people are not aware, even pediatrician, I would say, because I get patients when they say that we told the doctor that my child is not speaking at 2 years, 3 years. They said, we'll wait till 3 years. So this is
5% लगवा दूं मैडम हैं
hello.
iPhone 2, please mute yourself. Thank you.
So, and there is a lack of awareness. There is limited resources. There is stigma. That's the most important thing. Everybody goes to the net and reads. The first sentence written in the net is that there is no cure for autism. The moment they read this, they are disturbed. They don't go for assessment. They don't go for the diagnosis. They go into depression. So let's understand that autism is not a disease. It is a condition where child is learning differently. He or she has a difficulty in social interaction and communication. The child does not find any interest in interacting with people, but we can do that. We can improve the interaction. We can teach the child. So it is not that these children cannot learn. So it is our duty to identify these problems early, especially during the first 2 years. That is called the golden period of the children. When the brain is developing, there is a neuroplasticity. And if you teach these children can do very, very well. And the other limiting factor is the social attitude and financial constraint. So all these, and there is not much support from the government. There are certain myths in the society, as Dr. Rajni was saying. So I have added the slide in today's presentation. The very often we say कि and as we say, autism is more commonly seen in boys. ladka hai late bolega, and the father also spoke late, it is okay. So they keep on waiting till 4 to 5 years of age, and by that time the important golden period is already gone. So there is nothing like, there is no literature which says that boy speaks late. And here what we are talking about, not about speech, we are talking about interaction, and speech is just one of the presentation. There would be children with autism who are speaking fluently. We get children of 2 years old who can speak the Hanuman Chalisa, who can speak the Gayatri mantra at 2 years, but they do not know where is the mother, where is the father. So there we need to understand what is the meaning of autism. And very often parents are blamed and parents are feel guilty, especially during the COVID time. The children were exposed to a lot of excessive screen time. Yes, it should not be given for sure. According to American guidelines, there should be zero screen from 0 to 2 years of age. And any child who has autistic predisposition and they are exposed to more screen, it increases the symptoms. So excessive screen time should be avoided. And generally parents feel that we are not trained about parenting, nobody has trained us, we are reading this, we don't know how to pay. So autism is not caused by bad parenting. None of us has been trained about parenting. As soon as the child is born, the parenting starts, you start learning parenting. So, and every child is different. So here the answer is you need to understand the need of the child with autism, that what does his requirement. What you know is a typically developing child. And very recently there was a study which showed that vaccine caused autism, for which there was you people must be aware, especially the pediatricians are aware, the children were not getting the vaccine, especially MMR. There was hue and cry about that MMR is causing autism. So this is a myth. There is no scientific background for this. A child should get all the vaccines without any danger. Then talking about the treatment, there are various treatments has been recommended. There is no single treatment which has been recommended for these children. But as you can see this list, there are number of injection, immunotherapy, chelation therapy. A lot of people are given doing, heavy metal chelation in these children. Some people are giving secretin injection. Some are doing sensory integration, giving high doses vitamin, gluten and casein free diets. But as I'm showing in this graph, that these are not supported by evidence till date. So only evidence-based recommended therapy is the behavioral intervention. And there are some antipsychotic medicines like risperidone, which can be given for comorbidities, as Dr. Rajni has already discussed about it, the comorbidities. Rest of the treatment are still under research. And because these children with autism are chronic conditions and they run from post to pillar to get the treatment done, and whosoever says anything, go for, you must have heard about stem cell, hyperbaric oxygen and all those stuff. So FDA has heavily cracked down upon this, and they have given recommendation that these should not be given to children with autism. No stem cell therapies, no hyperbaric oxygens, no miracle mineral solutions, and other things which has been written. So then what is to be done? So as we know, the standard treatment guidelines given by the American Academy, by the Indian Academy of Pediatrics is that first make the provisional diagnosis. As a doctor, all of us know that the most important thing is to make the diagnosis. As I get more children at all the ages, and I've seen children do not get diagnosis till 5 to 6 years of age. They avoid getting the label of autism. So till the time you will not get the diagnosis, the child will not get the proper treatment. They will be getting just some therapy, either occupational therapy or speech therapy. These are just symptomatic therapies. These are not the therapies based on the core deficit. So although no single therapy has been proven till date, but aim of the therapy is to target the core features of autism rather than just focusing on delayed speech and hyperactivity. Remember, children with autism will speak until unless they have associated language disorder. Speech and hyperactivity should not be the area of concern. These are just symptoms. And all the interventions, this is a multidisciplinary program, has to be made. We have to make the goals under the supervision of developmental pediatrician, and there is a team of therapists, including special education, occupational therapists, speech therapists, psychologists, and others, and make the plan as per the need of child. It has to be all individualized plans as per the need, and these plans should be should be done so that there is an improvement in the home and community based interactions. It should not be clinic based. You must have seen that some of the children who are going for therapies, and therapists take the child to the room and close the door and does the therapy behind the doors. So there is nothing like that. For every intervention, it is a blanket statement. For every interventions, parents have to be the role, has to play an important role in the therapies. Only therapists cannot improve the child. So until unless any therapy in which parents are not involved, that means he is not getting the right therapy. Then pharmacotherapy can be offered. It is given only for specific target symptoms. Management of the comorbidities is very, very important, like intellectual disability. As I said, autism is different and intellectual disability is different. Very often we get confused. The child is not doing the work because so we use general statement like he's intellectually disabled. So intellectual disability is a separate entity, like typhoid is separate and malaria is separate. Similarly, in developmental language, autism is separate, intellectual disability is separate, ADHD is a separate entity, which we have to identify and work on those areas. And those programs should be reviewed and modified over time. And whatever therapy we are doing has to be goal oriented. It has to be, if any therapy which is non-goal oriented, arbitrary, unending, repetitively based only on the symptom-based intervention, it should be avoided. I will just give you a brief outline. I cannot discuss the whole therapies here, but I'll just give you the brief outline and few names so that at least you should be familiar. There is a term called ABA, which is applied behavior analysis, in which is the generally used for the treatment of autism, in which the core basis is ABC. What does ABC mean? For any behavior coming in a child, for example, child is crying, so we have to understand, or he's shouting or he's snatching from you, we have to see what is the antecedent. What happened before the behavior comes and what happens after the behavior comes. So if the consequence, for example, if a child wants a chocolate and he is snatching from you and you gave the chocolate to the child, the consequence is favorable. So next time if he wants the chocolate, he doesn't know the appropriate way of communication ki de do. He will come and snatch it from you and he gets it. So to change any behavior, we need to work on either A or the C. So these are the basic principles. But ABA version now is not the only treatment which is used. The latest treatment modalities which are used is called NDBI. That is naturalistic developmental behavioral intervention, in which we follow the developmental approaches. We know that the child follows a developmental sequence. Every child follows a developmental sequence. That means first he starts sitting, then standing. It is not any child who is not sitting will not stand. Similarly, in all developmental domains, maybe it is cognitive, language, social, motor, mental. So all the developmental domains, they have to follow a certain sequence which is taken into account, and it has to be done in a natural environment. It should not be done only on sitting on a table. It has to be done in a natural environment. And we have to follow the child's lead. As I said earlier, child is not interested in interacting with us, but we can interact with the child. We will involve the child. बच्चे के साथ बच्चा बनना है, उसके साथ involve होना है, and then we have to teach the skills which is called joint engagement, joint attention. There are certain skills which are missing in these children. We have to teach these skills. So emphasis should be on the developmentally based learning targets and on the social learning skills, delivery of interventions in the context of naturally occurring social activities. So the principles of this naturalistic developmental intervention is that the treatment should be started early in life and delivering the treatment throughout the child's day. It should not be done that the child is going to the therapy center for 1 hour or so and that's what he's getting, or after coming back home mother is sitting on the table and doing two. No, it has to be done throughout the day, when the child is being fed, when the child is getting the bath, when the child is going to the bed. Every time, the whole day, child has to be involved and taught the various skills, and these skills has to be tailored, monitored, and we have to see how is the treatment implementation going on. And for this, a team monitoring, team person, team leader, the form of developmental pediatrician has to be there who can follow all these programs. So these are the basic principles of development. I will not go into this detail. I think this is not needed. Language development, whenever we are talking about language development, use natural language, affectively rich displays of gestures, emotional, facial, and vocal expressions. There should be an animated body language so that child is connected and child is towards, and which enhances the child engagement with the therapist. And then we have to teach the various skills in cognition, language, and we have to make a complete plan. These are the names of various programs which are used for this training. So I will not go into this detail. I will just, in the end, I will just show you one video of an autistic child so that you can see a child with autism can improve, and it has to be very, very hopeful situation. Child should be given a lot of hope. This is a child who presented to us and who does not speak anything, who does not make an eye contact with the mother. He just snatches whatever he wants and he is busy in his own. And he was diagnosed with autism. So as you can say, he is happy doing his own activities, but after doing interventions and therapy, child is so as you can see, I'm sorry. So as you can see, the child start learning, and this child got the best, most amicable child of the school. He got the award. So children can improve if we focus on early identification and treatment, and we target the core deficits of ASD rather than just focusing on the symptomatic treatment, which is the problem, which is a very big problem these days. And therapy should be that targets developmental principles in the naturalistic environment should be encouraged. Thank you so much.
Thank you, Praveen, ma'am. This was wonderful. And you have cleared so many confusions from our mind. So, ma'am, you are basically dealing with the developmental, pediatric population. I read somewhere that, there is a variant which presents in adulthood also, because it may be subtle. So, are there any definitive therapies for adults also?
Let's understand first the basis of autism, because as I told you, there is a problem with the social interaction and social communication. So in older children, they would be talking, they will be going to school, they will be doing all the activities. There will be kids For example, he's going in older population. I'll just give you some scenarios. For example, a child of 6 years old who is going to school, he's studying well also, but if he's been told jokes or somebody is making fun of him, he's not aware. He cannot understand. So autism is a different picture. We do not confuse between intellectual disability and autism. Autism child can be extremely brilliant also, can be extraordinarily brilliant also. As you said, in adults, yes, there can be those who are not picked up or those who are very, very fine. And I also mentioned the point that as the age increases and social demand increases and child capacity is not enough, then these symptoms become prominent. I had a patient who came to me at the age of 24, 25 years of age by the parents. He was a married boy, and he was brought that he has difficulty in relationship with the wife. And when I took the history and had gone back into the history, then I gave the diagnosis that this child initially had autism and he never got the treatment. So at this age, what we can do is behavioral modification and helping them with teaching the social skills and how to build relationship. We can guide them on that. For other people, we do not have to teach. They learn on their own. Here we have to teach them.
So thank you, ma'am. I think we can discuss it over in panel discussion also. So Veronica, are you going to take over or should I introduce the moderators for the panel discussion? Dr. Ravneet Kaur. Dr. Ravneet Kaur is Associate Consultant Medical Genetics, Fortis Hospital, Mohali. She is MD Pediatrics, DM Medical Genetics from AIMS, New Delhi. She has been ex-assistant professor, PGIR Hospital, New Delhi, ex-consultant medical genetics, Motherhood Hospital, Chandigarh. More than 10 publications to her credit and has authored many chapters in national textbooks. So metabolic disorders are her area of expertise. Our next moderator is, please show the, yeah. Our next moderator is Dr. Latika Bhalla. She is Senior Consultant Adolescent Pediatrics, Institute of Childhood, Sir Gangaram Hospital, DNB Pediatrics and Diploma in Adolescent Pediatrics. Then MSc Fellowship Endocrinology from South of Wales, London, Consultant Adolescent Pediatrician for last 20 years at Sir Gangaram Hospital. Many awards and accolades to her credit, many publications also. And we have some panelists also. First of all, there is Dr. Aradhana Dwivedi, MD DNB Pediatrics, first medical geneticist from Indian Armed Forces Medical Services, and she has set up genetic services in defense forces. Congratulations, ma'am, for that. She is currently working at Army Hospital Research and Referral Center, Delhi. She's an alumni of prestigious AFMC, Pune. Numerous publications in peer-reviewed national and international journals. Her main area of interest is prenatal and cancer genetics, lysosomal storage disorders, dysmorphology, etc. She is currently a member of IAP, Society of Indian Academy of Medical Genetics, and she has been involved in many research projects. So our next, Dr. Chanchal, I don't think so she has joined right now. Is Dr. Chanchal here? She's MD OBGYN, FRCOG, FICOG. Fellowship she has done from Singapore for maternal fetal medicine and UK accredited also. She's the lead consultant fetal medicine at Madhukar Rainbow Children's Hospital and Birthright by Rainbow at Malvinagar, New Delhi. Many academic activities to her credit. Foxy Rajatre Fetal Medicine Runner-Up Awards 2320, Editorial Board Journal of Fetal Medicine. Many publications to her credit in peer-reviewed journals. And the next is Dr. Rinky Tandon. She's MBBS DNB Pediatrics, Sir Gangaram Hospital. And she is FIAP Developmental and Behavior Pediatrics, Sir Gangaram Hospital itself. And Consultant Development Pediatrician, Max Super Specialty Hospital, Saket, currently. Director Creative Mind Child Development Clinic, New Delhi. She's trained in Bailey Ivy, trained in understanding and applying sensory integration therapy. She's the life member of IAP and other chapters of neurodevelopment and pediatrics, etc. So over to moderator for the panel discussion. So if there are any questions from the attendees, you can put in the chat box so that our moderator and panelists can take care of them also. So over to you, Ravneet, madam.
Thank you, ma'am, for the kind introduction. So I share my screen. Just give me a minute, please. I hope you're able to see my screen.
Yes, ma'am. Visible, ma'am. Visible, audible and visible.
Okay, thank you. So I'll start with the case. So there's no point of case one because I have only one case. So there was a 4-year-old male child who presented with history of developmental delay, and this was the complete pedigree. So we see that this is the proband, and he had a younger sister who was normal. And in the detailed family history, we saw that there was history of early menopause in her grandmother, in his grandmother. So on examination, he had global developmental delay, some autistic features. Then there was facial dysmorphism. He had long face, large ears, hyperextensible joints. So we suspected Fragile X syndrome, and we got the FMR1 CGG repeat TPPCR, and we got that there were 250 repeats in the TPPCR. So now the child had presented here with the recent developments that now at 12 years of age, this child seemed withdrawn. He had lesser interaction with the parents, although he was already on therapies, but now he had started having behavioral aggression, and especially when the outsiders were there at home. So my first question is for Dr. Latika. Ma'am, we want to know that what signs might emerge in adolescence for children with autism, and how can puberty influence the behavioral or cognitive symptoms, and especially in Fragile X syndrome?
So good evening, everyone. It has been my proud privilege to be on this platform. Thanks to Dr. Veronica, Dr. Anita, and Dr. Mala Srivastava for creating this CME. As a lot of things have been already discussed by Dr. Rajni also and Dr. Praveen Suman also. All this normally has to be diagnosed in the age group as early as 2 to 3 years, maybe earlier than that also. In IAP's program of 1000 days, there has been a specialized program, specialized instructions for the pediatricians to refer the children to the development pediatricians whenever they find certain red flag signs. But still, a lot of children or a lot of people or a lot of unaware parents sometimes miss certain things. So as all of us know, in the adolescent age group, it is the amygdala, which is the ruling brain, which is the ruling part of the brain. So that is the reason for them to have a heightened fear response. There could be a heightened anxiety, emotional dysregulation. And as all of us know, there is a decreased prefrontal cortex activity till the age of 25. So that also may be responsible for the poor impulse control, decision making, leading to both the changes, especially in the cognition also and in the social behavior also. So there are certain neurotransmitters which also play a lot of role, like a dopamine. There are altered pathways affecting the reward processing and social motivation. GABA lowering activity leads to poor sensory regulation and emotional control, and serotonin elevated linked to repetitive behaviors and mood issues. So what we normally see is the emotional and behavior concern. So most of the time, all the adolescents are always worried. How do I look? Who am I? So there is a constant search for their identity issues. So that is why there may be a heightened emotional sensitivity and a lot of mood swings also, which otherwise are also very common in this age group. And they may show, sometimes they may be totally withdrawn, irritability, and there may be a poor peer acceptance. So अगर आप किसी बच्चे से पूछोगे, sometimes they may tell that the older child does not have the friends. He never had the friends, but the younger child had the friends, and they are making the friends with each other, and he's playing with them. He's interacting with them. But the older child never had their own friends, which is very difficult for them to have a peer acceptance. So leading to isolation or behavior outbursts. Other thing which is very common, as all of us know, that there has to be changes in the social behavior. So there is a difficulty in the reading, implicate or social rules leading to unintentional social mistakes. Some they become more agreeable or people pleasing to avoid social rejection, or sometimes there is an over preference of online socializing due to predictability and control over other things. And sometimes we have seen some certain children, the girls especially, so these girls sometimes they become more friendly, so they are into certain like they always find to connect and over agreeability with other people, and then they may compensate for their lower academic performance by doing certain storytelling also, and then that is how you can recognize. But only thing is that we have to, whenever there is a problem with the social interaction, whenever there is a problem with the social interaction, people will never come back to us. Most of them, they start coming to us. There are, as they start going to the class 8th or 9th, as they going to higher classes, most of the time we see there is a definitely change in the academic activities, and that is why they lead to, and they do tend to come back to the either pediatrician or a development pediatrician. So very important for all of us is the heads assessment. So whenever we are doing any adolescent child, whenever we are doing your physical examination history, menstruation history also is, nutrition history is also important. Heads assessment, I think, is the most. Heads assessment is a acronym. So this will tell you what is heads is a home, so how the child is behaving at home, like what kind of parents, siblings, then the education, then their eating behaviors, activities, substance abuse, whether there is any history of like smoking or any alcoholism at home, or maybe there is a spirituality, how inclined the child is to the spirituality. All the heads acronym, if we do in all the children, they will give us some idea how to go. So most of the time we are doing almost heads assessment in all the children who are admitted to pediatric ward in Institute of Child Health. And I think in the last 3 months only, we are able to find out there are a lot of stressors which probably have never, most of the children who have come to us, they have no issues pertaining to any psychological issues. Most of them, the children, we are asking them the history, they have come with their physical health problems. So that is why it is very important that if we can do the psychosocial behavior assessment of the children, even by doing heads assessment, they can give us an idea and we can refer them according to the problems they are having. And then comes the how can puberty influence behavior or cognitive symptoms in a fragile X symptoms. They do definitely have a very important, you can say, there are definitely because of this in the behavior issues which are very specific to the Fragile X syndrome. So in the boys, we have a physical symptoms of macroorchism, flat feet, lower like muscle tone, and but as the children are growing up, hyperactivity, impulse control, difficulty and attention, increased anxiety, social interactive difficulties, social withdrawal, and there are challenges in making the peer relationship, as Dr. Praveen Suman was talking. So most of the time, once they grow up, they do not interact very well with the peer group, and there is always problem in the relationship or a relationship formations. And sometimes there are, because of the social and emotional changes, they can have aggression, and speech and language difficulties are also there. So very important for us to talk to them. There has to be open communication with them. So there was one child who came to us. We need to talk to them about the puberty. We need to talk to them about the sexuality. So all these things are very, very important. And then there is has to be development appropriate support. So if we are ready for that development appropriate support, that is also very important. And third thing which comes and very important is the self-care strategies. We need to teach the children how to look after them. So these are the most important things which, as a pediatrician or a gynecologist, or maybe any child who is coming to us, an adolescent, we should be able to help them and to refer them for various, like even for the psychoregulation or psychobehavior regulation, to the development pediatrician or maybe to the psychologist also. Thank you so much for the patience.
Thank you, ma'am, for a wonderful explanation. So my next question is for Dr. Aradhana. So, ma'am, for our audience, can you please explain the difference between a premutation and a permutation in Fragile X syndrome?
Good evening, Ravneet. Thank you for this question. Hope I'm audible.
Hanji, yes, ma'am.
Okay. So basically, when we look at the Fragile X, now it would be more appropriate to call it as a FMR1 gene-related disorder. And when we look at this disorder, on one end of the spectrum, we have full Fragile X syndrome, which is because of the CGG repeats more than 200. So when we call it a full mutation, we are referring to more than 200 CGG repeats, which are seen in FMR1 gene. And that gives rise to a typical Fragile X syndrome in males mostly, because it's an X-linked condition. And when we're talking about the premutation, normal CG repeats in any human in health is about 5 to 44. Then we look at somewhere between 45 to 54 is considered the intermediate allele. And from 55 to 200 is a premutation. So again, these premutation, those who are carrier of this premutation, whether male or female, they are not that they are fully healthy, they are at risk of certain conditions which are known as Fragile X associated tremor and ataxia syndrome, which is late onset disorder with tremors and ataxia, and more common in males who are hemizygous for this. And females who are carrier of the premutation, they are at risk of premature ovarian insufficiency, which is seen about in 20% of the females who are carrying this vis-a-vis 1% of the normal population. And one more condition which could be associated with the Fragile X associated neuropsychiatric disorders. So full mutation is more than 200 CGG repeats, while premutation is between 50 to 200, which are associated with these disorders. Now, the next question is, what genetic counseling should be provided to the mother and maternal aunt? So as I said,
back to the pedigree then.
Yeah.
So the mother has a younger sister who's 37 years old, and she might plan another pregnancy. So what genetic counseling you would offer, ma'am?
Okay, so in this case, then there is a male child who is affected with Fragile X syndrome, and then in this case, the mother would be carrier. So for all these FMR1 disorders, who is a child with Fragile X, the mother would be heterozygous, and in that case, all we do, mother and their female relative, that is in this case her sister, should also be offered the testing, and who are heterozygous for the, as I said, they could be premutation or the full mutation, and the mutation may change. The premutation converts in the full mutation in gametogenesis. So the premutation for the mother or this lady who's carrying, she should also be offered testing for CGG repeats by TP-PCR or the PCR. And if she's found, then she has, again, there is a risk of having a child who can be affected. So typically the 50% risk of recurrence in male child, and then females would be carrier, and obviously males will not pass on their premutation to the sons. So in all, if there is a family in which there is a male child who's affected with Fragile X, then the mother and the female relative should be tested for that, and mother is taken as a heterozygous for the condition.
Yes, ma'am. So now the next question was for Dr. Chanchal, but since she's not able to join, Aradhana ma'am, would you please like to take the question again? So what is the role of prenatal diagnosis like CV and amniocentesis in Fragile X syndrome? So if we find out that the sister is also a carrier, so then do you offer prenatal testing also?
So obviously when the sister is a carrier, we would like to offer. Now the question is, what do you want to offer? You want to offer CVS or amniocentesis? So typically a CVS gives answer easy, earlier in the pregnancy, but in this case, particularly because Fragile X, the FMR1 gene CGG repeats are causing methylation abnormality. So methylation pattern of the chorionic villus may be different from the fetus, and we face the problem of confined placental mosaicism. So in these cases where we are having methylation issues, CVS would not be a better test. Amniocentesis would be preferred over CVS, because CVS can give false negative results. It may not represent the fetal methylation status exactly. So I would like to definitely basically, in fact, Fragile X is something condition which has been recommended to be tested preconceptionally, along with thalassemia and SMA. There is a screening for Fragile X for ladies which has been recommended by guidelines, national guidelines. So, and then once you found the carrier, it would be better to go for amniocentesis because that would give us better status of the methylation and testing.
Yes, ma'am.
What about
So,
fetal imaging? Because
Okay, yes, and I'll just now the next question is how do you counsel about the this
pre-mutation in the
repeat
fetus.
pre-mutation? So that's what we have to say. As I said, pre-mutation is basically 55 to 200 repeats, and then we can say that if we found a pre-mutation in the fetus, then we can say that yes, the fetus is not going to be affected. Depends on the male or female. It's a little tricky situation because with the pre-mutation, as I said, it will not be full-fledged Fragile X, but then yes, the conditions which can develop later onset, the tremor ataxia syndromes, the premature ovarian insufficiency, etc., and then a female will have a risk of pass from pre-mutation can come to full mutation in her reproductive counsel. We have to do the reproductive counsel in case of her. So all these things should be counseled when we find a pre-mutation in the fetus. Coming to the fetal imaging findings, which are associated actually. Truly speaking, there are no sacrosanct findings which we can say that is associated with Fragile X. But as more and more studies are done, it has been that maybe some amount of the ventriculomegaly could be associated. NT is usually not a marker. We don't find increased NT and it doesn't correlate well with Fragile X. Mild ventriculomegaly may be seen. If we go for fetal MRI, maybe abnormal cortical development, which is picked up, maybe a pointer towards that, but then still it's in the research stage only. We don't have any telltale signs or fetal imaging findings which are absolutely connected with the Fragile X as of now, to the best of my knowledge.
Yes, ma'am. Thank you so much. So my next question is for Dr. Rinky. What early intervention should be initiated following an early diagnosis? If we consider the child was diagnosed at around 4-5 years of age, then what early interventions do you recommend? Is Dr. Rinky available with us?
so if she's not there, you can take the
Dr.
answer
Rinky
also,
was here,
or
ma'am. I've
anybody else.
seen. Dr. Rinky was here. I've seen. She joined, I think. She was there.
Hello, ma'am, I'm here.
Yeah, madam is
Thank you.
there.
Sorry, ma'am, I was on mute. Okay.
Okay. So, ma'am,
Yeah.
the question for you is that what early intervention should be initiated following an early diagnosis?
So, after making a diagnosis of autism, the early intervention should be started. It should be started by the multidisciplinary team supervised by the developmental pediatrician. So, which involve the occupational therapist, the speech therapist, the behavior therapist. So, and these interventions should target the core features of autism. They should be evidence-based. They should be structured and based on the developmental and the functional needs of the child. So there is need to test the cognitive ability and the adaptive skills testing before starting the intervention to make it effective. So there are various intervention models like ABA-based therapies. As Dr. Praveen ma'am has already explained, it uses A, B, C. So A is the antecedent, like why a particular behavior is coming. B is the behavior, and C is the consequence, how the parents are reacting to that problem. So in this case, the child is showing aggressive behavior when someone is coming from outside. As these children, they face lot of sensory sensitivities. So in this case, so if we need to identify the trigger here is the trigger here is the other member from outside is coming. So that is causing aggression. So this can be modified. So we can modify the antecedent by modifying the child's environment. That is called child proofing. So there should be a calm and supportive environment for the child with we should like decrease the sensory load of the environment, like decrease if there is loud noise or bright light. So by decreasing that, we can modify the behavior of the child. So providing a calm and supportive environment is essential. Then using visual schedule and also clear, consistent routine and clear and concise language should be used. So to modify the antecedent. Then, so this way we can modify the behavior of the child. Also, we can modify the parents can use the modeling as a way to improve the child's behavior, and they can teach the communication skills to the child. Then we can modify the consequences by using the reinforcement or by giving reward for a desired behavior. Then there are naturalistic development behavior intervention, as Dr. Praveen ma'am has explained. So NDVI-based approaches which are done in the naturalistic environment of the child, and that is more important. The home-based and family-centered approach is more important, as the child needs behavior therapy for around 25 to 40 hours in a week, and that cannot be done in a clinical setting. So the parents or the other family member or caregiver, they should be trained about the home-based intervention, and also by the involvement of multidisciplinary team. And also the family should help the child in involving in day-to-day activities as we all do normally. Then also the families can help the child in connecting with the social environment. So that is very important. Then there are other models and NDBI based model like an early start Denver model. So it is a comprehensive NDI based intervention which uses ABA as the therapy model. So and along with the relationship based approaches to enhance the social skills of the child. Then after that, speech therapy. So speech therapy, like if the child is not communicating, the child is facing problem in communicating his or her desire or need, then we can try various modalities, augmentative and alternative communication devices, maybe use of sign language or picture exchange communication system, or maybe speech generating devices. So basically these are tablet-like units which help the child in communicating their desire and or needs by generating the electronic voice. So if suppose a child presses wants apple, so he or she can press the button on the device with the picture of apple. Then automatically the voice will come, I want an apple. So this way we can enhance the communication skills of the child. Then the sensory integration therapy, as struggle in taking the sensory input from the environment. And also the children with Fragile X syndrome, they are very sensitive to sensory environmental stimuli. So there is a need of a sensory integration therapy given by the occupational therapist. Then occupational therapy for the fine motor deficit and for adaptive deficit like self-help care skills is needed. So we should review the intervention plan and modify according to the child's ability and needs, as the child ability and needs changes with time. So if there is no improvement after appropriate and intensive therapies, then we can think of starting pharmacological management for a specific target symptom. Like if the repetitive behavior is coming, like in this case, there is the child is having aggression. If that is not improving after intensive and appropriate behavior therapy, then we can start with the risperidone. So
Okay.
yeah.
So I think the second question is already covered now. So ma'am, there's a very important question. How do you coordinate the transition to an adolescent pediatrician then when the child grows old?
So to coordinate a transition from the pediatric specialist to the adolescent specialist for a child with Fragile X syndrome, it is crucial for a proactive and collaborative approach. So there should be involvement of the child, the parent, and the healthcare professional. So this includes planning early transition, like before the child's 14th birthday. So as this is the period of significant physical and psychological development, and we should involve the adolescent in the transition process. Also, the families should be involved, as the families play a vital role in supporting the child during transition. Then ensuring the adequate support for the child needs, like medical needs, like ongoing health condition or any medications. Then supportive needs, like identifying the type of support the child is taking, like the type of intervention the child is taking, including the behavior, the social skill training, or the occupational therapy or sensory integration therapy. Then uh, there should be a goal development, smart goal development, which is specific, measurable, achievable, and relevant, and time bound. Then communication and collaboration between the specialists is very important to for sharing of and in records, for sharing of medical records, for sharing of information about the child. Then collaboration with other specialists like occupational therapist, psychologist, occupational therapist, and speech therapist, to provide the ongoing support and to address the specific needs of the child. And the role of family is definitely important. Then we can teach them about the education program, then the various support, we can teach them about various support groups and advocacy organizations, and about the disability certification and the benefits for these child.
So, yeah, I just want to add one line, because there are special guidelines under by the American Academy of Pediatrics, where whenever we have a transition in any from childhood to the adolescent or maybe to the adulthood, so there are special guidelines where how to transfer the child to make it more like the smoothen the process, so that there are lesser side effect of transition. Or sometimes if the children are not ready, first we have to make the children ready by the age of 12 years, and then the transfer should be done by the age of 14 years, as explained by Dr. Rinky.
Sure. Thank you so much, ma'am. Thank you to all the panelists for a wonderful discussion. So I hand over to, I think, Dr. Veronica for the conclusive remarks.
Dr. Veronica, are you there to conclude? Please stop sharing, Ravneet.
Sure.
Ma'am, there are questions in the chat box. If people can take, would be better. There are
Actually,
2-3
we are very
questions.
late, I think. So
Yeah, most of them have been answered.
Yeah.
Praveen madam has also answered. Like most of the questions, they were referring to how to refer, whom to refer. You have to refer the child if you suspect to a developmental pediatric specialist. I think that will be the correct thing. And furthermore, if any referral is required, they will themselves coordinate, as it was discussed in panel discussion. So are there any specific questions, we can take them. Otherwise, we can just wind up if there are no more discussions, point of discussion. So, Sulekha ma'am, you want to add anything?
We want now, I think, very wonderful webinar, and all the topics are covered very well, very informative, very practical. It opened our eyes, and thank you all of you, for being here and joining in this webinar. So let us say good night now.
Yeah, it's late. But there was a question regarding Duchenne muscular dystrophy if associated with autism. So I think this needs a separate, session or something. If in 2 minutes, Praveen ma'am, you can just answer the query.
I can maybe, ma'am, answer
Yeah.
that.
Yeah, sure.
One third of children with Duchenne's muscular dystrophy do have autistic phenotype, and this is because the DMD transcript is also expressed in the brain, and only some of the transcripts are expressed in the brain, and if the autism is caused due to those deletions of the transcript that are expressed in the brain, there may be underlying autism also. So 1/3 is a big number.
Thank you.
So we can propose vote of thanks now. Thanks to Sulekha ma'am for joining as our chief guest. Thank you. Thank you.
It was lovely meeting you.
Thank you. Our pleasure, ma'am. Thank you. You have made our webinar so successful by your esteemed presence. Dr. Arup sir, thanks to you, Dr. Mala Srivastav, and all my learned speakers, moderators, chairpersons. I need to thank all of them individually. Thank you so much for increasing our knowledge today. Our panelists have been brilliant. We missed Chanchal, of course. Dr. Ravneet, thank you. Dr. Latika, Dr. Aradhana Dwivedi, and Dr. Rinky, thank you for your wonderful inputs. Thank you, Praveen ma'am, for your wonderful presentation. Veronica, as always, has been super brilliant. Thank you, Veronica. And thank you, Harsha ma'am and Chandra, dear friend, to join and encourage us for carrying out such webinars in future also. And thank you, Mala, for always being a guiding force. Thank you, Indian Academy of Pediatrics, the developmental, branch of that. It was lovely interacting with you all. Thank you so much. And above all, my special gratitude to all the delegates who have joined in large number, and still some of them are with us. Thank you so much for making our webinar a great success. And my special thanks to the pharma support given by Mr. Ajay. Thank you so much.
And strengths also.
More than 70 delegates have joined.
Thank you, ma'am. Thank you so much. It is a privilege for me to thanks to all the office
Thank you,
women,
Vairo.
especially iSOPARB and
My thanks to
chapter also, ma'am. I'll be doing further more webinar if we get the chance also, ma'am.
Yeah, so many people are asking for the link, so it will be very kind if you share the link.
I'll share the link after editing the YouTube, ma'am. We need to edit something which is not good. So once we edit, we'll share in the Facebook and the YouTube. I'll share the link also, ma'am.
Thanks to Rajni, Farmania also for that lovely presentation. Arup sir, will you like to?
My special request to all of you, to member of the iSOPARB.
Yes.
And all the juniors to make the member. It's a fantastic webinar today. Really, many things we have learned from this. So my special request, all of the juniors of your department and the other juniors and pediatrics and obstetrics and gynecology, please make them member iSOPARB. Thank you.
Yeah, thank you, everyone. My special thanks to Veronica for coordinating everything, for suggesting me the brilliant faculty. Thank you so much, dear. Thank you so much.
Thank you, ma'am. Thank you, Veronica, ma'am.
Thank you, everyone.
Good
night.
Good night.
Good night.
Good night.
Nice.